Okay, hello everybody, and welcome to our fifth episode of the Community Health and Capital podcast. I'm here today with Professor Jennie Popay. Hi, Jennie.
Hi, Johnny.
Jennie is here. She's a distinguished professor in sociology and public health from Lancaster University. Jennie, I heard briefly talk at the People's Health Assembly over in Argentina, and I think has got a lot to talk about around, I think, one of the kind of main principles our Wellbeing Centre Nightingale Hills wants to really operate towards, which is community involvement. But I wonder, Jennie, if you could just tell us a little bit of background about yourself. First of all, what's your story?
Well, it's probably too complicated to tell you all my story, but as you said, I'm a sociologist. I've been working in public health for some decades, really, and I'm particularly interested in health inequalities and the structural or social drivers of health inequalities. As you probably know, Johnny, I get very frustrated by the focus on behaviour and lifestyle when we know that health inequalities are actually driven by the conditions in which people live and work, and by the misbehaviour of corporations and government's inability or failure to address that via policy. So over the last, I suppose, 20 years, I've been particularly interested in this community approaches to addressing some of those, what I refer to as structural drivers of health inequalities. There's, whenever things start going pear-shaped with the economy, the community comes center stage again. It's like it's the silver bullet for fixing problems when the economic climate is getting more challenging. And it has been over the last 20 years, of course. So I'm a bit obsessive about exactly what we think we're doing with these community approaches, really.
Can be a double-edged sword, can't it? Okay, yeah. So we're very keen in lots of guises to look at how we involve community members and residents. And obviously there's a little bit of a potted history of that in the NHS, really. I just wonder if you could tell us, how do you think things have fared when the NHS comes to engaging with communities over the years, and what's your experience been?
Most of the work I've done has actually been in public health, not in the NHS, right? So it's been more about community approaches to in place-based work, in neighbourhoods and that kind of thing. But in the NHS, I think the story of public or community involvement is not a good story, really. There's been a lot of well-intentioned aspirations to involve people collectively in decision making, but also at an individual patient level. Yeah. I think the NHS has probably done better with the individual patient level involvement. Sure. So I think genuinely health professionals really do now try to work in partnership with individuals who come into the care system. They may not always do it as well as they would aspire to, but it's kind of at the forefront now, I think, of professional practice. And so I think that has been a positive story, from the kind of doctor knows best to a situation where people with health problems who are coming to health professionals are treated as knowledgeable about them. So I think that's a good story. We can always do better, but I think it's generally not a bad story, that one. Where the NHS has singularly failed, I think, is in more collective involvement, whether that's communities of interest. So by that, I mean people who share a particular interest. So they might be people with disabilities, or people from very marginalized groups, or communities of place, so neighbourhood based, which is very important for primary care, isn't it? And I just think there's been attempts from the community health councils through all sorts of other initiatives. I was on the Patient and Public Involvement Commission for Patient and Public Involvement, which had a couple of years of life before it was abolished. Yeah, no, not long. And in fact, my friends from then, there have been several other commissions and things that I've been on that have been abolished. They now believe that actually, if you want to get rid of a commission in the UK, all you have to do is appoint Jennie Popay to it.
I'm sure that's not the case. I'm sure that's not the case.
But that, and I think so. There's a long, complicated history of the NHS trying to do things about collectively involving people who share an interest, whether it's an interest in place or something else, in at a more policy level, in making decisions about what kinds of services should be provided, how they should be provided, where they should be provided. And I'm sure there are some good examples individually around the place, but in general, I think that's not worked very well. And certainly with the Commission for Patient and Public Involvement, I think that experience made it very clear to me that one of the reasons it doesn't work very well is because at that kind of strategic policy level, the NHS is not very good at sharing power, really. And it's very threatening to do that. And I think the reason things have gone pear-shaped is at least in part because there's been a lot of resistance to that. And to do it properly, of course, you do have to share power. You have to genuinely share decision-making, which is about sharing power.
So it's interesting. I wonder why you think, on the one hand, the NHS has accepted patients as being a partner in a clinical kind of consultation or a kind of clinical setting, yet there's this kind of dichotomy with the kind of more the service planning side, really. Is that a kind of managerial issue, you think, more, or is it still the kind of health professions feel a little bit of that resistance that you mentioned?
Well, I think, for me, I might be being too simplistic, but I think I can understand why at the level of individual patients, health professionals can see the logic here, that actually you do need to understand where people are coming from if you want the work you're doing with this patient to be maximally effective. And so it's self-interested, isn't it? As well as ethically, I'm sure that, and the kind of values agenda is, but there's that ethical, values-based push to work as equal. It maps really well onto the idea of wanting to maximize the impact you have, and do that by understanding where the person is coming from, what they think the problem is, and kind of having a dialogue about the best way to deal with that problem. So I think that coming together of a very practical benefits with the values and aspirations is why it's working at an individual level. And it also feels good for professionals, all health professionals and managers. They want to, in my experience, they generally, I've met a few that don't, but most of them are genuinely wanting to have a positive impact in the work that they do. And so you've got a kind of, there's a plus virtuous circle going on there. But I think at a strategic level, that's very different, because that's about money, it's about resources, and I think that accepting that collectively the public might have wisdom to share about the way services are actually designed and delivered is a very different dynamic than doing it at an individual level. I think so.
And I can see it's something you're obviously passionate about, but what in your view would be the kind of reasons you think people should be involved in the planning side of healthcare, and what benefits do you have in your head that they could have?
Well, because I do believe that, I think that I believe it, I know it from the research I've done and others, that that he who wears the shoes, she who wears the shoes knows where they pinch, right? So, and I think there are many examples of that, where collectively bringing that kind of wisdom from experience of living in a particular place, of, bringing up children, looking at caring for elderly people or people, that kind of collective wisdom, different from the individual wisdom, the collective coming together of that wisdom is a powerful source of evidence for policy, really. And there are, I mean, the Grenfell fire, for example, is in the public health arena, is such a powerful example of the problems you get if you ignore that wisdom. So those residents of that tower for 10 years before the fire were telling the housing management company and the local authority about all of the problems that led to the fire and caused the type of fire it was. It was all on record. It was on their website. What they got was a solicitor's letter from the local authority telling them to desist, otherwise they would take legal action. And then what you got was this horrendous fire with, 80 odd people dead and thousands, hundreds at least traumatized. So, and I think there are mirrors of that in the clinical world as well. So I for me, the benefit is this enormously rich body of evidence from experience that we're missing when we make decisions about services. And you won't get that it's a bit like the arguments in the research world about one individual can give you some powerful insight, but if you bring numbers together, you really do create a much richer set of evidence, whether that's qualitatively with 20 people or quantitatively with 1,000 people. It's not just additive. You don't just get a kind of you expand it in a much deeper way when you bring people together.
And it's interesting you bring up Grenfell and housing, because I was wondering, in your experience, do we single out the NHS as being kind of uniquely quite poor at engaging people on the planning side, or do you think this is a problem of public services as a whole? Or?
I don't think it's only public, actually. I think the private sector is just as bad. In fact, I think they're a bit more manipulative in the way that they use, the marketing stuff is. So I don't think it's only the private sector. And in fact, that idea that the private sector doesn't do it well, so let's give it. I'm not saying you were saying that, but I think it is a kind of knee-jerk reaction to say, the private sector of healthcare will do it better. No, they won't do it better. Because it isn't only about the public-private divide, really. I think it's about power. I think it's about power. I think what we're not doing is we're obsessed with community assets, and mapping them, working with them, whatever, and we just fail to see the primary issue here is about power dynamics and understanding power dynamics, so that you can making them explicit, understanding what positive type of power is available here and operating here, what negative type of power or limiting power is operating here, understanding those dynamics so that when you're working jointly with communities, you can address those power dynamics. You can think about how do we maximize the positives and minimize the negatives here. Sure. And that I think doesn't matter whether it's in the public sector or the private sector. People who enter a space as lay people will have less formal power than whether it's professionals or marketing directors or whoever it is in whatever space, corporate or public. Does that make sense?
It does make sense. Yeah, it makes a lot of sense. Just to, I suppose, think of other contexts. I wonder if you'd come across any other countries or health systems where they've managed to maybe kind of embed this a little bit more on the healthcare side.
Well, I think there are some examples, and they're not perfect, but so the Aboriginal health services in Australia, which have been a bit undermined recently. Fran, who you met in Argentina, would know much more about this. It might be worth getting her to talk about it, or some of her her colleagues from the Aboriginal services, but they're a really interesting example of a community-led, community-controlled services, where the professionals, where they can, the professionals are also from the Aboriginal nations, but not always. And so it's a model where you've got equal partnerships between the community and the people who are providing the services. And I think where it has worked well, it's worked really, really well, that model. The other example is that I think in Brazil, they've under Lula, now back, isn't he? They set up a democratic healthcare system, at primary care level, but not only, where they have neighborhood. It's a bit like our community health councils, except they are very embedded in the neighborhoods. And our community health councils were very English, weren't they? With, you know, representation, was a local authority on there and some community people on there, and you know, so it was very formalized in that way. I think the Brazilian model is a neighborhood-based model, but they have a kind of neighborhood councils, and then they have regional councils, and then they have a national, and at each level they send reps to the next level. And one of the evaluations that was done of that a few years back that I saw, so I'm not sure where it's at now, because of course the Bolsonaro years would probably have undermined that.
Yeah.
But it was very positive about the way in which local people were able to influence the way, certainly primary and community services, but I think the hospitals as well were provided, and you know, so it was a genuine attempt to have a participative democratic model in healthcare. And you know, I think that, as I say, it was, if I'm just trying to remember the organization in Brazil that did the evaluation, Fiocruz. It was Fiocruz, which is an interesting organization in Brazil. They also, I mean, again, I'm a bit out of touch because I'm not sure what's happened over the last few years, but they also they produce medicines, drugs, pharmaceuticals, Fiocruz. It's a kind of public model where they produce pharmaceuticals, but they also do research and they provide healthcare. Primary.
Yeah, we'll have a look into it.
Model. It's been around for some years. So that's another, but you know, that I mean, somewhere like Wales could do that, couldn't they? They could do that.
Indeed. Yeah.
Much more challenging in England for all sorts of reasons.
Yeah.
You know, somewhere like Wales and Scotland could move in that direction, and they're so far away from it, really. No.
Give it time. We need to start somewhere. So I suppose kind of nationally, the kind of policy space around this has been hit and miss, I suppose, really. You know, sometimes some progress, sometimes steps back. And I think it's interesting that I believe for a period, the GP contract in England mandated practice to have to be having this, but yet it still hasn't really managed to progress. If you were to flip around and look at starting in a local place, what would be the steps you think you would take to trying to kind of mainstream community involvement and ceding power to residents in planning the services?
I mean, the model I have looked at in the past is called community-oriented primary care. Don't know whether you've come across that. It came out of South Africa and Israel, actually. Sadly, it's a long way away from where they are now. But and that, what they did was set up. I mean, and I know some primary care groups do have this. They started with a bit like the early model of the Sure Start, where they had members of the community on a management group, you know, not just one or two token, but genuinely a kind of genuine partnership between members of the community. And I think in the Sure Start centres, they had parents on the Sure Start management groups, and the early evaluation of the Sure Start centres in that first 18 months was really positive about that model. And they were actually, it was Fiona Williams at Leeds did the evaluation, I think, and the argument was that model of having parents on the management group and then parents in other groups or who were actually working with professionals, so they weren't ceding power.
Mhm.
That's really important to me. This is not about do it yourself. It's not a DIY model. It's a genuine co-production model. So you're sharing power. You're not ceding power to the community. Because the GPs and the nurses and the receptionists, they all have their own wisdom to bring, don't they? They all have their own evidences to bring. So I think it's about creating knowledge spaces, decision-making knowledge spaces where you can bring different kinds of knowledge together and find ways of knitting them together, because they will always be in agreement. So the Sure Start model would help, I think, for your centre to think, okay, what did that model look like to start with? Because you'd have to think about, well, are you going to have elections for local people? Well, you don't need to do that. You find your activists in the community just to start with, and that you would actually be saying to them, this is temporary. It's not a place for you forever. I want you to help us think about the model, what the model could look like and how it could be more porous, so that people don't have to sit on a management group to have a voice. And I think the community-oriented primary care models that were most successful did that as well. So the one I remember, honestly, this was 30 years ago, 40 years ago when I was looking at this, when it was very active. But they were, the local people, this was in South Africa, were bringing issues from their community, which were then shared with the care providers. And there were things like housing and income and air pollution and, as well as child pneumonias and, things. Vaccination issues. So some of the priorities that were being adopted by the community health centres were being strongly influenced by in the area and using the services.
That was one of the strong, I think, messages, from our first podcast with Mark was Healthier Fleetwood had initiated this process of just a monthly meeting, community members, same day, same time, same place, aiming to kind of figure out, I think, what was affecting people, I suppose, first and foremost, really, but what were services not necessarily doing. I think the magic that Mark seemed to spell out was they'd managed to kind of engineer that not just for the healthcare services, but for all the public services in that area to really listen and engage to that, really. And I think it's figuring out the various different processes, mechanisms for it, really, because it can't just be one or two people sitting in a management group. It has to be so much bigger and wider than that, doesn't it?
Yeah, it does. But I think that, I don't know what Fleetwood has done now, but I do think that you shouldn't only start with consultation, because that's such an old model. It was very successful in Fleetwood, and I think that, and it's not a blanket criticism, but I think at the beginning you need to have multiple ways of doing this. So identifying just a few people that would be willing to be involved in the management process, as well as monthly consultations or whatever it is, and maybe other routes. So you should, I know it might feel overwhelming, but I do think you need multiple routes right from the start to have to give people voice, really, not just the consultation. That is a step, but it's too often seen as, well, we do this and then we'll Whereas actually you can do them at the same time.
And of course some people, we need to be more proactive to reach, really, don't we? So relying on kind of a single kind of place or meeting probably isn't going to be sufficient.
And you can use the existing conduits, because as you know, there are very few groups that are actually hard to reach.
True. Yeah.
They're not that hard to reach, and there are existing networks that you can use. But there are always issues of trust, I think.
I just wondered, Jenny, I mean, with your academic hat on, obviously public involvement has become a bigger and a bigger thing in research and academia. And I presume that has probably changed significantly over the years. Really, there's probably been a big journey there. Is there anything we can learn from there in terms of the kind of culture change needed, or kind of how it started, where it's got to?
I mean, I think that power issue is for me, one of the most important things, that we still haven't positioned power as a central issue, you know. So and I think that does require a lot of work with professionals about what you actually mean by power, what kind of power they have, because some of them can feel quite powerless, I think. So so that's one thing that I think has been, if you look at the research, it's not often talked about as research, but if you have that lens, as power, if you have that lens, you can see that many of the reports are talking about power, you know. And the other lesson, I think, from a lot of the evaluations is that there's too much of a focus on the internal dynamics of communities, you know, I call it the inward gaze, so that a lot of the work that local authorities and the NHS do under the community engagement or involvement umbrella is focused on building community, let's say, you know, this kind of notion that there's some, even though the deficit model has certainly been weakened, there's still a notion that we have to somehow build capacity for action rather than releasing it. So I think that one of the issues about the change in perspective, I'm not sure it would be culture change, but the change in perspective is that notion that communities have enormous capabilities and capacities. Problem is the barriers that are in the way of releasing that, at the same time as saying, actually, we're not just loading this onto them. It's not a question of them doing it themselves. It's about us doing it together. So I think that's another strand. And the third strand with that internal external gaze, I think, is this issue about it seems to be a really powerful driver, lifestyle drift, you know, that so many people in public health and healthcare, health and social care, start off recognizing health inequalities, the social drivers of health inequalities, the fact that this is about the conditions in which people are born, they grow up, they live, they work. It's about their lack of power to change any of that. They kind of know all of that. They talk the talk. And then what do? They start focusing on cycling and diet, you know. So, and that is still the case. You know, if you look at a lot of, I mean, a lot of the community initiatives, they're still largely focused on that kind of lifestyle, even if it's done at a collective level. So it's about cycleways and parks, and, you know, rather than telling individuals what they should do, it still seems to be difficult for the system to move beyond that and focus externally on social justice. Really, how will your kick address social justice issues? You know, what and how will you make sure that those issues are center stage when you're working with the communities that are using the services, and, you know, and that's really difficult, I think, to get to keep that focus external on social transformation or justice. Really,
it's a bold challenge. I've definitely heard some interesting lifestyle suggestions, including putting weighing scales in GP practice waiting rooms to encourage people to check their weight. And in the mind boggles.
The latest one I heard, I've been involved in an initiative around blood pressure, and hypertension. And of course, it is a major problem, isn't it? Undiagnosed hypertension, or diagnosed but untreated, or, and it is a major problem. And I've been working with this group of health and social care professionals and some communities around what do we do about it? Because in this population, there's a really serious problem with hypertension and the consequences. And what do we get? Well, what we've got to do is put blood pressure monitors in barbers' shops, And I could have, at the end of this workshop, I could have pulled my hair out. I just thought, how did we get there? How did we get to? And one of the community members, who was great, he said, I go to the barbers to relax. I don't want a blood pressure monitor in the barber.
Yeah. It's encroachment of medical intervention sometimes, really, isn't it? It is tricky. It is tricky because there is obviously an unmet need, really, but it's when we do that solely at the exclusion of other wider things at the same time.
I'm not even with that sure. It's so, I mean, Johnny, I would say that blood pressure monitors in barbers will make no difference at all. So you clearly do need a way of helping people to understand the consequences of walking around with very high blood pressure. I think a lot of them do understand those consequences, and it's just their life priorities, actually.
True. Well, Jennie, thank you so much. There's so much to think about on I think, as well as the kind of the reasons for why we should be going this direction, and kind of how we sell it to the local services at the end of the day, really. But I think it's also been really helpful to know some of the kind of practical ways we could embed and install this too. I look forward to coming back to you and laying out how we plan to respond to your challenge of how we're going to embed social justice at the heart of what we do in the Wellbeing Centre and the KIC. I
look forward to hearing how you're getting on. It's very exciting. Great opportunity.
We're really excited. Yeah. So thank you, Jen. This has been a 5th episode of the Community Health and Capital podcast. Please get in touch if you've got any questions or comments about this episode or would like to feature an upcoming one. And we look forward to sharing with you in a few weeks our next episode. Thanks, Jennie.